Hello everyone, welcome to Hot Seat. I'm Omid Moghaddas from Tehran, and once again, I'm so grateful and thankful to be with you all from this platform in the series of online webinars with dear friends and colleagues from around the world. And today, again, I'm so excited to be the host of one of the great friends and skilled surgeons from LA, California, in United States. Alexander Amir Aalam is here with us. Hey, buddy. Welcome to the hot seat.
Hi.
Thanks.
Good morning. Thank you.
Thank you so much. Thanks again for accepting this invitation. Today, I have to say that I'm so excited to have you with us because the topic that he will present for us is one of the most interesting topics for the periosurgeons, for implant surgeons, which is the fibrin-assisted soft tissue promotion, specifically called by FASTP, New Horizons in Mucogingival Procedures. I'm pretty sure most of you may be familiar with this technique or seen it in his presentations or on YouTube, on Facebook, some of the clips of it. But today we will go in depth of this procedure, which is one of the, I think, amazing approaches in treatment of gingival recessions. I'm sure that you will enjoy this presentation, and at the end, we will have a brief discussion and question and answer about the topic. So as a tradition, I will have Dr. Aalam's CV for you all, and then we straight go to the presentation, and we won't wait too much longer. He graduated with DDS degree from the University of Nice, Sofia, Antipolis, France, and subsequently specialized in advanced periodontics at the University of Southern California in Los Angeles. He is a diplomate of the American Board of Periodontology, diplomate of the American Board of Oral Implantology, and a fellow of International College of Dentists. The French Society and the California Society of Periodontology awarded him for his contribution to clinical research in the field of implant dentistry. He is a clinical associate professor at the University of Southern California School of Dentistry in the Department of Advanced Periodontics. In 2012, he was appointed as the USC Dental School representative on the board of the governor, and 2019 as a member of the board of consular. He maintains a private practice in LA limited to periodontics and reconstructive implant dentistry, and lectures and publishes in the field of dental implant and site development procedures. Once again, I'm so happy to be your host, my friend, and we are ready from head to toe to hear your beautiful presentation.
Thank you so much. Thank you, Omid John. It's a true privilege and honor for me to be here and being able to share this hot seat with me. Can you see me, guys? Is that okay?
Yes, it's perfect.
Okay, let me go back. So it's a true privilege and honor for me to be here and share this hot seat with you. I just want to congratulate you because I know that these days are not easy for all dentists, all practitioners. Most of us are locked down home, and it's very reassuring to see that we have leaders such as yourself that are taking the initiative to take the flagship of continuing education and putting, webinars, seminars, continuing education out there to keep the community, busy and just offset our mind from this pandemic and sharpen our skills and just feel better and do what we do every day, which is good dentistry. So today I'm going to share with you a concept that we developed with my wife and Dr. Joseph Shukroun, which is the fibrin-assisted soft tissue promotion, which is, I think, an innovative, an adjunct that we have in mucogingival procedures in order to help us to improve the predictability and the clinical outcome for our patients going towards procedures of root coverage. So as you mentioned, I am from Nice. Nice is a little city close to the south of France. It's a city very similar to San Diego for our Californian friends. And I moved to Los Angeles in '99 to do my residency program at USC. And this is where I met my wife. My wife, Alina, she's my business partner. She's my business in crime. We live together, we practice together. And sorry?
You can share
and we
also.
So, yes, how?
I mean,
Hello?
we don't have your screen now.
Oh, you don't have my screen.
You can share your slide. I thought that you may want to talk on the slides.
Yeah, of course. Share screen.
Yeah, good. Now we have it.
Go back here.
Yeah.
How do I get it up here? Sorry. I'm so sorry. Here we go. You got it?
Yeah, it's perfect now.
Good. Perfect. So my wife Alina Krivitsky, she's a hygienist, she's a dentist, and she's a periodontist, triple Trojan that I met in the program the first week that I came to USC. And we share this passion of teaching, we share this passion of practicing together, and we have a practice that we run together in Brentwood, Los Angeles, where we are concentrated in the field of periodontology, reconstructive implantology, and mucogingival procedures, mainly what is concerning of her practice. So as periodontists, as reconstructive surgeons, oral surgeons, the gold standard that we have for our treatment outcome is based mainly on the utilization, of course, in our opinion, of the utilization of autograft. Now, it doesn't matter if you're using hard tissue grafting or soft tissue grafting. We all know that autogenous tissue coming from the patients will provide us with the best long-term and the most stable clinical outcome. But as we know as well, harvesting from the patient is associated with some limitations as well. The main limitation that we have to face is obviously, as we all know, the concept of morbidity. Every time that you have to go and take some bone from the chin of the patient or the ramus of the patient to do a bone augmentation, or if you have to go and harvest some connective tissue from the palate of the patient, really no patients want to go to that procedure, even though they understand that this is for them the best way to reconstruct the ridge or reconstruct their tissues, but truly nobody's excited to have their chin open or their ramus open or have sores on the palate. And therefore, sometimes, and most of the times, case acceptance or participation of the patient or sometimes even the referral doctors don't want their patients to go to these high yield procedures because of all the maintenance that comes with these procedures and the babysitting that has to come following the care of their patient. So we have a lot of resistance associated coming with these autografts related to the second site, the morbidity and the discomfort. And another limitation that we have to deal with is the amount of tissues that we can harvest. Today, our patients want to have everything done immediately. They want to have their full mouth reconstructions done within hours. They are not willing to wait anymore. And if we tell them that they have to come back and get 4 or 5 grafts done to be able to reconstruct their tissues around the roots, sometimes after the first and second surgery, they give up. They say, you know what, I'm sorry, I'm done with it, and I'm just going to live with my recessions, and that's the end of it. Or if you tell them that you have to open 2 ramus and a chin to do your block graft and your sinus lift, patients may not be very happy about it. So the amount of tissues that can be harvested on one patient's procedure is, again, a big limiting factor that sometimes forces us to break down the procedures in multiple steps. And for these reasons, the industry has shifted and introduced the utilization of substitute. Soft tissue substitute represented mainly on dermal product or on bone graft particles and represented mainly by allograft and xenograft grains, particles that we can buy off the shelf in bottles. But as we know as well, those products, those substitutes have limitations as well. And one of the main limitations is the cost. Of course, every time that you open a box of dermal product to use for a root coverage or open a jar for some bone grafting, you're adding hundreds of dollars to the cost of your treatment that has to be eventually passed to the cost of your patient's treatment value. So that's, of course, a big limitation. There is, of course, the concept of quality. You have to remember that the type of tissue, the type of healing, the type of attachment that you get sometimes, especially using xenograft materials or tissues coming from a different origin than self, is questionable. And a lot of time, when you look at histologies, we see that we get scar tissue more than any true attachment or true regeneration that we get around those roots and repair, maybe most probably the proper terminology to be used rather than regeneration once we use this substitute. And of course, even though it's very difficult to prove, the risk of disease transmission always exists. We know it even now, even more with this pandemic, that we have hundreds and thousands of viruses, prions, that we're not even able to detect because we don't have the technology. Look at what's happening with this COVID-19. The tests are not even available or just barely breaking into the market right now. So we know that there is most probably hundreds and thousands of viruses and prions that are even actually smaller particles than the viruses that are difficult and impossible for us to diagnose today and can be transferred from animals to humans, and therefore even more today, this risk of disease transmission, I think, is more important, and our patients are aware of that. Now, knowing what happened with the wet markets in some of the countries today, I know that today none of my patients want to hear about any xenograft material coming from pig or from cow. This is something that is just not willing to be done today in our practices. So those are limitations that are associated with the utilization of substitute. And for me, the ideal, if you had to like close your eyes and make a perfect flow chart of an ideal bone graft to an ideal substitution for a tissue graft material, would be a material or a tissue that would be from an autogenous origin, meaning coming from the patient, from self. It has to have a low cost, meaning that you can treat all your patients without any financial discrimination related to the money associated with it. So that means that all your patients could benefit from the gold standard treatment without thinking about money, about savings, or having patients refusing treatment because they can afford it. Product that can be available in limited quantity, meaning that you can do a full microconstruction, hard and soft tissue in one visit, limiting as well the morbidity for your patient. And of course, having the highest quality clinical outcome associated with the long-term as well, maintenance of your clinical procedures, because of the fact that you're using a tissue that is recognized by the body by self, and therefore will not trigger any autoimmune response in the long term, and therefore will not be subject to a severe amount of resorption. So, sorry, I'm trying to change my slide. Here we go. So, perfect. Close to 7-8 years ago, when I witnessed this miracle of life, I saw my wife, Alina, pregnant with my first daughter, Amelia. And I was just puzzled. I was puzzled by this engineering, how a whole human being was able to be fabricated within 9 months. And this human being had these highly sophisticated organs, such as brain, kidney, liver, legs, arms, nerves, vessels. And us periodontists, surgeons, highly educated people were not able to grow a couple of millimeters of tissue around the roots or around the bones of the alveolar process. And once we did that, we made slides and we went all around the world and start promoting our skills as surgeons once the ladies in our community, in our lives, are doing that every day, millions of times a day. So at that time, I realized there has to be a way. There has to be a technique, there has to be a way to channel this self-wound healing that we have in ourselves as human beings and be able to build back the attachment apparatus around our roots, which is simple. If you look at the big picture of life here, some attachment, some cutaneous tissue, or some bone around the roots of our patient's roots, and be able to provide them with a clinical sound outcome. And my research at that point led me to the meeting with Dr. Joseph Choucroun that I think I met through social media. By the time I was scratching my head, not understanding how I could find a solution. And Dr. Choucroun in the early 2000s was working a lot on the concept of PRF. And he's a physician. He's not a dentist, as you know. So I called him up. I said, Joseph, you know, you are a physician practicing the south of France, from the same city that I'm from. And I'm a periodontist in Los Angeles. And I know you have done some work with some dentists concerning bone grafting, sinus grafting with your PRF, but have you ever thought about using PRF to rebuild some attachment around roots, around teeth? And the answer was no. So at that point, we start our collaboration and we introduce the concept of PRF in the mucogingival procedures. And our first paper that was published in 2013 was the introduction of the APRF, which is one of the latest versions of the PRF family, into the world of dentistry. So as you know here, and I'm going to be very brief, PRP, PRF, all the blood-derived growth factors are not new into the dental field. They have been introduced by Dr. Marks from the University of Florida from the late 90s and all the way to 2014 and 2017 now with the IPRF. And I know that, I believe Rick Myron did a presentation for you, I think not too long ago, and most probably he has introduced the CPRF and the albumin PRF that was introduced by Carlos Mura, I think in 2018 as well. So there is a lot of changes that happen, a lot of modifications, a lot of improvement. And one of these amazing findings for me is that the organ, which is blood, that is one of the most common organ that we have in the whole entire humanity, is like oxygen, right? This is something that we all have. Every day we're finding some new properties. Every day we're finding some new growth factors. Every day we're finding some new ways of utilizing it in order to improve the quality of our healing and improve the patient's quality of care. So this is fascinating to think that blood, which is something so common, is still underdeveloped in terms of our knowledge into it. And every day, new advancements are coming, and I cannot wait to see what's going to happen in the next 2 years because things are moving fast as. So PRF is not a solution to all your problems in dentistry, unfortunately, as we see on social media. Okay, so you have to understand the limitations and understanding how the product and the concept works. And I would not want to use the word product. It's actually a thinking process. It's a philosophical approach to a treatment that is the main concept of this PRF. Basically, what PRF is just a fibrin clot. It is just a clot that is supercharged with growth factors that are going to be released into the surgical site over a period of 2 weeks. And during that time, this release of growth factor are going to kickstart, to ignite the wound healing process, induce neoangiogenesis, and accelerate the formation of new tissue on the site. And that's all PRF does, and that's all the different versions of PRF does. Okay, so that's important to understand that if you summarize all the different families of blood-derived growth factors, this is the only attributes that they do have, which is kickstarting the wound healing process. So one of the questions that I get a lot from my students and from my peers is that, so what is the difference between PRF and PRP that we used to have a couple of years ago available in the market that is just not so attractive anymore? Well, if you look at the content on your left-hand side on this table, both of them have pretty much the same amount of cells and leukocytes. But what makes the difference between these two techniques, these two families of blood-derived growth factor, is the preparation. The PRP needs a double spin, which means they have special tubes and special armamentarium that can add up to $100, $150 per patient's harvest, which adds a lot of cost to the treatment, and that defeats one of the attributes that I mentioned to you about at the beginning of this presentation, is to have a concept of treatment that is cost reasonable. And another major difference is that those tubes are coated with anticoagulant. Again, remember that those anticoagulants are, they used to be actually with the thrombin coming from bovine, again with the risk of disease transmission, which we know today are real, coming from animal to human. Or now today we know they're using saturated dextrose, which is again a man-made one. But the whole concept is that you're changing the homeostasis of the growth release factors coming from your patients because you're changing the blood release factors and the natural way of the release of these cells as well. One of the biggest factor that is going to change the way that we use this growth factor as well is their release form and their handling. As you know, PRP is a liquid and therefore does not have any physical texture, and then using it becomes very difficult because you have to mix it with a carrier to be able to have this sustained release during at least a period of a week if you want to see any clinical ramifications of your treatment outcome. So these are basically the main differences, and this is again a little illustration that you see here given to us by Dr. Shamlu in 2012. On the left side, you see PRF, it's the release of this growth factor drop by drop, like an irrigation system in your garden that will release this growth factor over a period of 2 weeks. And the PRP is just taking a bucket of water and throwing it into your lawn here. So you get a huge influx of growth factor, but then it will dry up immediately. And then you have to inject again and inject again to be able to maintain the concentration of the cells and the leukocytes in the cell. So what made me interested mainly to work with the PRF family, and especially with the APRF, is because the APRF is the only blood-derived growth factor, and I just repeated very clearly because we have research to support this data. APRF is the only growth factor, blood-derived growth factor, that has been shown to be able to isolate BMP2 and BMP7, which are the bone morphogenetic protein coming from the patient. And I know this is debatable because they are in the form of trace on nanograms. And to be quite honest with you, we still don't know today the exact amount of these BMPs that are needed clinically to see any relevance. But the truth is that they are available. And by changing the spin and slowing down, and we'll talk about the low spinning concept today, we're able to capture those monocytes that are the precursors of the release factors for those BMPs that are needed for obtaining a better quality of hard and soft tissue. So this is the difference between all the other growth factors that we had today, the blood-derived growth factors and the APRF. And this is, I think, a very important point because we are on the right directions trying to isolate this transforming growth factor beta that will hopefully release enough BMPs to start seeing clinical relevance, especially once you deal with bone and sticky bone, and we can hopefully have another discussion with that, but when it comes down to hard process building. So again, these are tables given to us by the group of Dr. Shukru, and you can see here with time, there is a constant release of this growth factor, a drop and drop irrigation into the surgical site, a physiological release of this growth factor that is important in order to be able to start seeing clinical changes during the entire step of the wound healing process that takes weeks and days and not only hours. And as I was telling you, you can see on the left-hand side here that we're able to isolate up to 100 picograms of BMPs into these APRF membranes. And the most important factor for me is the isolation of 50% of VEGF, which is the vascular endothelial growth factor, which is the precursor of neoangiogenesis. So it's a combination between bringing the blood supply and cell differentiation between those two type of growth factors that will eventually make the clinical differences in your patient's outcome. So this is a little summary that I picked up from the internet. Everybody have seen, I'm sure, this little diagram here that it summarizes very well that you see PRF here has released all the different growth factors, cytokines, and lymphokines that you have that are important during the entire wound healing process. So it's important to understand that you have the entire gamut of growth factor that are needed from the time of the tissue injury and all the way to the epithelialization of the wound, which means the closure of the wound. And this epithelial growth factor is mainly important, especially once you deal with dental implants and on your guided bone regeneration to obtaining primary closure of your wound. So again, in a nutshell, one of the main questions that I get is that which PRF should we use? And I just summarized that in this table here, and just to show you the differences in the protocols that we have. And the summary is that the less you spin, the slower you spin, the more powerful is your blood-derived growth factors. That's basically the history that you see happening in this table, coming from the LPRF that is almost 15 or 12 years old, all the way to the IPRF and the CPRF that we have right now, is that the slower you spin, the less time you spin, the more powerful is your PRF. This is the clinical relevance. And this is where we are today with the low spin centrifugation concept. This is a concept that was introduced by our friend, another fellow Iranian, Shahram Ganati, working from Germany. And what they did with Joseph is that accidentally they found that by reducing the time of the spin and the G-force, they were able to isolate into this liquid form PRF some hematopoietic stem cells. And as you know here, this is again tables given to me by our study group by Shahram Ganati, that we have close to 40% of hematopoietic stem cells into the bone marrow in the spine, but we have traces of them circulating, released by those red cells into the blood. And the PRF, the iPRF, the liquid form of PRF, is able to capture close to 2% of these traveling remaining hematopoietic stem cells by utilizing the marker CD4 negative, and we're able to capture those into the tubes of our liquid PRF. And this is again 2 papers that were published in 2017 by Joseph Shukrun and team as well. And you can see again showing that the slower you spin, the more powerful is your PRF. So this is really the message of these studies that you can see. So this is again a little quick video to show you how this iPRF, liquid PRF, is coming. It is basically the top part of the spin that you're collecting. We're purposely not harvesting the red cells, and now we have taken this liquid form that you're able to inject into the site of your surgery. And this iPRF has the advantage of not having, of course, all the different growth factors that your PRF has, but again has these hematopoietic stem cells that are very important. So now we have 2 different textures to work with. We have the APRF, which is a membrane, and you have now your iPRF, your liquid form. The iPRF will have all the cells, and your APRF will be your carrier. Because again, as you remember, iPRF is a liquid form, so therefore it does not have a texture to be able to use with. So we had to be creative with this technique because we want to get the best of both worlds. We wanted to have the membranes and use their physical properties and their slow release and their slow resorption rate of 2 weeks. But we wanted as well to merge it with the cellular content of the iPRF. So what we did is that we developed this concept of carrier concept, so which is mixing those 2 together so we can get the best of both worlds, using the physical properties of the membranes and the cellular properties of the liquid form. And this is the heart of this technique here, and this combination that gives us this wonderful clinical outcome. Again, another advantage of using, again, the APRF compared to the other families of PRF is that APRF is a porous membrane. Okay, so if you look at it from a histological aspect and from the microscopic aspect, you see that the LPRF, or the traditional PRF that we have, is very robust. If you look at the difference between those 2 membranes, the PRF membranes are very robust, very strong, very dense, compared to the APRF that is much more porous, that will allow the cell penetration inside of it. So as a carrier, using it as a carrier, we found that the APRF might have a better inhibition of this growth factor inside of them, and thus the release factor. So if you are looking just to have physical properties, for example, you want to use them as a membrane with no biological properties, closing a sinus membrane that is perforated, maybe the LPRF membranes that are more robust might be a better choice. But if you're looking at the utilization of this PRF for release of a growth factor or some biological release and cytokines and pro-inflammatory tissues, then maybe the APRF may be a better choice. So you can change the settings of your machine and use the PRF texture to the actual need of your patient's treatment. So if you look at this table, okay, of the physiological regeneration that was given to us by Dr. Lynch here, we see that this combination between the solid PRF and the iPRF fulfills the 4 cornerstones of this true regeneration that we're looking for. We have on the upper left-hand side the formation of a scaffold that is needed, okay? And this is given to us by our PRF membranes. Through these release factors of the VEGF and the surgical modifications that we'll talk now about the techniques that we have and respecting the concept of biointegrity, we're able to release this vascular endothelial growth factor that will send the signals to the surgical site and recruit the cells coming from the body, but as well now the cells that we have from the IPRF, and this combination will provide us with the best combo, giving us the best layout environment for tissue formation. And this concept was introduced the first time, so this is again not new. In 2014, at the first PRF symposium that was held at UCLA, and this was Dr. Peter Moy, myself, and Joseph Shukun were the three speakers for this first 2014 symposium that was introduced. So as we know, PRF again is not new now. Up to today, we have close to 600 or 700 articles that have been published in sports medicine, traumatology, cosmetology. This is something that is introduced and is here to stay into the field of surgery. I had the opportunity as well to be part of a group of research led by Rick Myron, and a conclusion that was published in 2017 is that PRF shows the statistically significant relevance in soft and hard tissue augmentation. So we know that this is here to stay. This is helping us in our patients' treatment, and we all see the benefit of the utilization of this technique in medicine and in dentistry. So now to funnel back to periodontology and to the topic of our discussion today, if you look carefully at the studies done by Tsai and group in Australia here, what they did is that they took some cells and they grew them on Petri dishes in vitro using the PRF concept. And they realized that they had an upregulation of the PDL ligaments when used against this PRF. And this is, to me, the first bulb that just hit into my head, because any type of true regenerations around root, we need to have upregulation of periodontal ligaments. Now, it is for obtaining an attachment or keratinization. We know that the PDL cells are the precursor cells that will help us to obtain such tissues. And another interesting factor in that, again, in vitro studies, is that they noticed that there was a dam regulations of epithelial cells, mainly related to the secretion of transforming growth factor beta. And again, we know every time that we want to do any guided bone regenerations or guided tissue regenerations, we want to exclude epithelial cells from the surgical site. So this was a very interesting coincidence into their findings that fulfills, again, the directions that we like to take in GTR and soft tissue healing. So the next group of Chang here, what they did is that they took the same base of the ligaments, and they went and studied and see exactly what is happening within those cells. Why is this periodontal ligament cells being agitated and multiplying this way? And they realized that the growth factors that have been found into the PRF have an important impact into the intracellular aspect. So basically meaning by the fabrications of protein and by therefore the multiplications of the PDL cells, but it has as well a great impact on the extracellular communication within the cells. So basically improving and smoothing the healing process and the communication within the lines of cells into this area. So the first procedure that we did as a proof of principle was this case here. This is again, this was the first case that we did close to 8 years ago to see if PRF had an impact clinically on PDL cells and on true regeneration. So this is, as you can see, a perfect ligature-induced periimplantitis. This is the patient that was going to orthodontic treatment. This ligature, this wire created some periodontal disease for this patient. And we thought this would be a wonderful model to test this hypothesis. So we cleaned the roots, and we did not know better than that. Remember that these were the early stages of utilization of PRF into dentistry and regenerative field around roots here. So we laid the flap, degranulated the area, detoxified the roots the same way that you would do with your guided tissue regeneration. And then we chopped a bit PRF membranes, the same way that you would put bone graft into the defect, because we did not know anything better than that. We did not know how to use it. So we used the PRF as a bone graft substitute, chopped it, packed it into the defect, and used PRF membranes as barriers on top of that and closed it. And you could see that 5-6 months into the healing time, we're able to develop and get a bone healing without using any substitute into that socket. So this was the first case that we did, proof of principle, that was very interesting, that showed us that yes, truly this PRF had a positive impact into the upregulation of the PDL cells, and therefore there might be a healing potential associated with this process. This is again a second case that we did, infrabony defect, tree-wall defect. Again, we used PRF as a bone graft, quote unquote, as a substitute. We chopped it, packed it into the defect as a filler, and we closed the wound with PRF membranes. Again, remember back then, 8 years ago, we didn't know how to use it more than that. Close the flap the same way that we do your GTR techniques. And you can see here the amount of bone healing that we got into these x-rays in the middle. And I changed the polarization of this x-ray to show you that this is not a bone graft. This is not a substitute. This is the patient's own tissue that fill into that area with just the activation, the ignition of this periodontal ligament. So thinking this way, we went back and looked at the literature with Joseph and Alina, and we could not understand, if we have such a wonderful philosophy, treatment modality, why all the research were inconclusive when it came down to root coverage. Why the research that was publishing and coming out into the periodontal literature when it came down to mucogingival were not conclusive, and results were not attractive, knowing that we have such a powerful tool that is working so well in vitro. So what we did here is that with Alina, we sat down and we read every single article that was published clinically concerning the utilization of PRF in clinic. And we basically categorized, based on our understanding of this concept, the failures associated with the literature in three families. The first shortcomings that we realized that the literature and the authors were facing is volume. Again, remember that there is only a picogram release of growth factors of these PRFs into the surgical site, and therefore you need to have a tremendous amount of PRF membranes into your surgical site. So most of the articles that show 1 or 2 membranes don't have enough power to start seeing clinical changes. And for that reason, we recommend at least 3 to 5 membranes per pair of teeth to start seeing changes. And this was, again, one of the big modifications that we brought into the technique compared to the originals, pioneers of this mucogingival surgeries. The second main concern that we saw here is that clinicians were using PRF interchangeably with connective tissue, and they were comparing these two as such. But we have to understand these are 2 different entities. PRF is a clot that does not have any physical properties versus a dense connective tissue coming from the tuberosity or coming from the palate of the patient that has a completely different sets of physical attributes, not only from a physical standpoint, but as well from a genetic standpoint. Remember from the studies done by Kering that the palate, the keratinization genes coming from the palate are dictating the type of tissue that you receive in the recipient bed. So these are, again, the studies that we're doing with the free gingival graft by harvesting tissue from the palate, taking the phenotype from the palate, which is keratinization, and transporting it into the zones that were deficient, and you would start seeing keratinization happening because we're transporting the genes from the palate to the recipient bed, and therefore the donor site will be the decisive factor. Versus PRF, it's the exact opposite. And this is the terminology that we've introduced with Joseph, is the terminology of promotion. The recipient beds decides. Remember, PRF just ignites and make the site stronger and better, feeding whatever the environment has to offer. So if your recipient bed has very weak tissues, no keratinized tissue, inflamed mucosa, the only thing that your PRF is going to do is to replicate more of this weak, inflamed, loose mucosa. This is not an inductive material. It's just going to promote by neoangiogenesis and cell proliferation the tissues that you have in the recipient bed. So once you use PRF, the recipient bed makes the decision about the quality and the quantity of the tissue you obtain. And this is, I think, the main difference between those two techniques and why they should not be used interchangeably, because of the mechanism of action that is completely opposite. And I think this is the main deceptions where people are facing, is that they are expecting to get the same result by using PRF instead of connective tissue, and the failures they're encountering. PRF, again, is a biological modifier, okay, and it has to be compared, such as you have to use PRF and compare it as using Emdogain or PDGF. It falls into the same categories of treatment philosophies and not as a connective tissue graft. So again, and this is again one of the limiting factors that you have to understand by using PRF, is that if your site is weak, then PRF is not the right technique to use for you. And maybe you have to use connective tissue graft, subepithelial or free gingival graft instead of your PRF, or use them as a combination and not as a sole product. And of course, the last concept is the concept of bite integrity. Okay, this is a concept that was introduced in 1998 by Professor Inberg, which is a pneumologist, who's a pneumologist from the University of Harvard, who basically showed us that every time that you have a tension, pressure on a cell, you will induce clinical changes by having anabolic or catabolic reaction, meaning that if you put pressure on a cell, you will change its internal genetic print, and the cell will now produce more or start resorbing. And this is exactly what we see happening with our surgeries. If and then this is works done by Pini Prato, you have a guided bone regeneration associated with a flap that has a lot of pressure, a lot of tension. We all know that this bone underneath will be undergoing resorption, excessive resorption. Sometimes we were not even expecting that. And we did not know why. We just knew that we need to have a passive flap. We need to have a relaxation of the flap. And this is exactly why this concept of bite integrity that induces the changes of the genetic expression of the graft material sitting underneath there. And the same with our mucogingival procedures. Again, remember the studies done by Pini Prato. He realized that every time that he has a very passive flap and he was able to place this flap above the CEJ, the amount of root coverage was much more predictable compared to flaps that had tension. In his discussion, if you remember, he was not able to explain to you why. It was just an observation based on the studies, but we know why now by the concept of bite integrity. So we have this explanation, this biological explanation about the flap tension and the negative impact that it has. And again, these are slides given to me by Dr. Mamoto, again from Harvard, that shows here that by having tension on a flap, you're not only reducing the amount of blood supply and the arteries bringing the nutrition to the surgical site, but you're as well reducing the amount of vascular endothelial growth factor that are needed for neoangiogenesis. So it's a lose-lose situation by having flap tension on your surgical site. So we had to go and modify our surgical techniques to satisfy this concept of bite integrity, because again, remember, our PRF membranes do not have any physical properties. It will start resorbing if you put too much pressure on it. It's just a blood clot. And therefore, utilizing our traditional surgical approach with an envelope flap or a tunnel flap was not adequate. We had a lot of failures. And again, these are pictures taken from the literature that were showing inconclusive outcomes. You can see they were using, again, envelope flaps. They were using frozen PRF membranes. Okay, so they used to go and take the blood at the center, and then the patients would go home, put the PRF membranes into the fridge and bring them to the doctor the day after for the procedure. In France, because phlebotomy was not allowed by a dentist, then you had to go and have that done into some centers to do that. And you can see the aggressive suturing techniques and the changes of the tissue texture that is happening due to the changes of oxygenation of the flap. So of course, when you have so much pressure and using PRF membranes that are avital at this point, there is no way that you can get tissue regeneration. So the purpose of this concept was to upregulate the PDL cells by respecting the concept of volume and biointegrity, and the hypothesis was for us to get root coverage and keratinized tissue. So now we're going to go towards the clinical aspect and show you this technique here. And again, as you can see, we have a panacea of articles that were published since 2014 about this technique. We have again, a couple of book chapters that were published, and you can see them available in the internet and they're available for purchase, and you can find them on PubMed as well. But again, as a historical case, this is one of the first patients that we treated here. This patient had, as you can see, class 1, class 2 miliary recession associated with teeth malpositioning, sclerotic dentin, gingival deformities. We did not know better than that. So what we did here is that we went to the same steps of our surgical technique by going and providing these patients with the root preparation to remove all the dentin and all the convexity that this root had. We went again and placed our composite into in between the teeth, because again we had to modify the traditional vista technique that was introduced by our friend Dr. Homazadeh, because we found that by using this technique we're having too much pressure on the gingival margins of our flaps, and therefore a premature resorption of the clot. So we had to use the technique used by Marcus Schutzler and team by using composites in between the teeth, so to have this tension interproximally and not in between the teeth. And did our vista incision, again promoted by Dr. Homazadeh, getting a wonderful flap relaxation. Again, this is beyond passivity. We want to have a super relaxed flap to avoid any tension on it. We will go ahead, of course, and decontaminate the roots with EDTA or any agents that you used to use in your practice. And therefore, at that point, start packing this casing that we prepared with our PRF membranes to the maximum. So there is no true numbers, because again, every patient is different. Every amount of release factors are different, but we want to place as many membranes as the site can receive. So it's not uncommon for a maxillary arch for us to put 20, 25 membranes per site to try to gain volume, because we know about the slow release factors. We go ahead again, this is one of the major changes that we had to bring to the technique, is to do deep internal matrix suture. These internal matrix sutures will have two benefits. One of them, of course, is to keep those PRF membranes on the roots, because again, remember, my goal is to try to upregulate the periodontal ligament cells. I don't have any interest to have this PDL cell, this PRF membrane to start traveling down the nose of the patient. Okay, so it's very important to localize and concentrate those PRF membranes on the surgical side. And the second advantage of this deep internal matrix suture is to make sure that the lip movement is neutralized, and therefore respecting again this concept of biointegrity. And the advancement now is done with our continuous sling sutures that we have in between the teeth, using the flowable composite that we place, so we can have a nice traction advancement of the flap, not having any tension, as you can see here, into the gingival margin of the flap where our PRF membrane is supposed to do its work for 2 weeks. So this is the case that we started with. This is the case that we have at 3 years. You can see that we're able to develop a quite stable perimucosal environment for this patient. And what is interesting for me to show you here is this cross-sectional of this patient's treatment outcome, to show you that we have an augmentation with volume. So this is not just a pretty coronally advancement flap. This is a 3D true augmentation of the patient's own tissue, because again, remember that these PRF membranes have been resorbed after 2 weeks. And what it did is to ignite the patient's own tissue formation. And the tissues that you see here are not collagen membranes. This is not pig, this is not cow, this is not dermis coming from patient. This is from a donor. This is the patient's own true formation, tissue formation. So again, this is a little video that I'm going to show you here that is going to summarize the steps of the surgery in motion. This is again a class 1, class 2 recession, again, remember those cases are old. These are, again, the first surgeries that we did with the proof of principle to see if this technique works. And what I will be showing you as well, all this surgery and all the cases, I will show you the cross-sectional and the side views, because I want you to understand that this is not just a coronary advancement flap that we have, but we truly have a full rebuilding of the three-dimension aspect of the patient's attachment apparatus. So the vista incision is done, as you can see, and we're going to use our traditional periosteal elevator. We have vista instruments that have been developed by our friend Homazadeh that you can use that are very helpful for this technique, and elevate a full thickness flap. So this is important to understand. This is a blind technique. We're using our touch for this procedure. It's impossible to go partial thickness into the depth of this flap and gain a flap relaxation, a tunnel that is created. So the full flap thickness flap is mandatory because to avoid tissue tear and the perforation. You can see that we have a nice relaxation of the flap. The flap has to be very passive. It has to almost drape the roots without any tension, okay? And this is the key. We want to respect this concept of biotensegrity, not having any tension. And you can see we can use, again, hygiene curettes to go ahead and start detaching as much as possible the tips of these papillas. And this is the weak point of your surgery, okay? This tip of the papillas are the weak point of the surgery, because if you're not able to go and release the tip of these papillas, you're not going to be able to get the advancement that you're expecting. And therefore, the amount of root coverage will be incomplete. We'll go ahead, again, with the high-speed rotary instruments, provide this patient with the same root preparation that you would do for your traditional root preparation for mucogingival surgeries. And you can see now here, we're just going to flow some composite in between the teeth to create this source of anchor for our vertical traction of the flap. We're not etching and we're not bonding. This is just a contraction of the resin in between the teeth that will lock it in place and will allow this composite to be immobilized. And this is, again, one of the huge advantage of this technique versus the traditional vista technique, where you have to etch and bond and then have to deal with removing this composite from the roots. EDTA is applied on the roots. We're going to clean the roots, and you can see now we're going to start backpacking the PRF membranes into the surgical site using our forceps. We're going from the back to the front, and the rule of thumb is that we pack it as much as possible. Minimum 3 to 5 pair of membranes for a pair of teeth. Do not go with less than that. You're not going to see clinical relevance. So it's very important for you to add as many PRF membranes as the site can take. And as I told you, 20, 25 membranes is a routine for us, okay? So we have 3 machines running simultaneously in the office once we do a full mouth case, because sometimes we have to take up to 36 tubes of PRFs once we handle a full mouth case. And we have 3 machines running simultaneously. So you have to be able to harvest that much tissue, that much blood from your patient. So you see we're packing them with the appliers. We are putting pressure coronally, because again, I don't have any interest to have these PRF membranes going up to the nose of the patient. They have to be localized and stabilized on the roots, so we can improve the chances of PDL upregulation, because this is what we're going for. So deep internal matrix sutures into the vestibule, making sure that we go under the PRF membranes, okay, under them, so we can track them and pull them. So you see when you suture the knot, the PRF membranes are pushed up towards the incisal edges, towards the CEJ. They are not squeezed in, okay, they're supported from underneath here, because again, we want to try to avoid as much as possible the marginal pressure that will induce premature resorption of this membrane. So we're going to do again 3 or 4 of those sutures to bring down the PRF against the roots and immobilize the tissue pressure. And we're going, of course, to close our flap. We like to use a glycolon suture. Why? Because glycolon suture is a resorbable suture that lasts for 5 weeks, and therefore we don't have to remove them. We used to use proline and nylon suture for these surgeries in the past, and it would be a nightmare removing the sutures. Patients had to be numb, and it will be a torture sessions trying to remove them. So we have now the tendency to use resorbable suture, lifelong suture, because they are not creating any foreign inflammation during this healing time of 5 weeks, and therefore not having any catabolic effect into the surgical side, which is important. We try to avoid using gut suture, okay, because gut suture will have inflammation associated with it, and therefore you'll have a catabolic anabolic reaction on the surgical side and not getting the clinical outcome expected. So you want to use, again, a suture that is inert and is biologically sound to the surgical side. Again, 6-0 sutures to do your coronally advancement flap here, and tract the flap as coronally advanced as possible to try to get root coverages using the marker sutular sting suture around the contact point. So you see, we did not invented anything new here. We just repackaged the different techniques from the Vista, from marker sutular, from Joseph Choucroun's concept. We just brought up and packaged it together into this surgical technique, which is the FASTP. So this is the patient's clinical outcome at 3 years. And this is, again, the side views to show you the volume that was gained for this patient, showing the beautiful integration of this patient's own tissue. Again, this is the patient's tissue. Remember, this is not, again, any type of membranes belonging to an animal or to a donor tissue. This is the patient's own tissue fabricating new tissue. This is, again, another interesting case here to show you the power of this technique when it's used properly. One single Vista incision has been done. We have teeth malpositioning, sclerotic dentin. This is a difficult, challenging case. And we have a physiological displacement of the flap due to the relaxation that we have, apical matches suture. And this is, again, the case before, and this is the case after. We can see the amount of vertical augmentation, which is, again, more striking for me, which is the most important picture for me, is a side view to show you, again, the amount of tissue, connective tissue, epithelium that was built up by this patient's own tissue by the upregulation of this PDL cell. And this is, again, histology now that I'm showing you that has been shown by Dr. Key in Australia as well, where he has PRF membranes placed under the connective tissue, under the skin of a specimen. And underneath on the blue here, you see connective tissue, and on the top, you see epithelium, and in the middle, this is the PRF membranes. And the 14 days, you see the relationship has changed. The connective tissue has been upregulated. You can see the fibers of connective tissue that have been hyper excited, and you can see the formation of this striation here, the resorption of this PRF membrane, and again, the upregulation of the epithelium. So this is not, again, a membrane that is being invaginated and used as a scaffold, but is just an ignition of the site and then the disappearance, the resorption of this membrane with time. One important picture here that I think that is that made it for me, again, this is a case that is almost 5 years old today. This is a case, class 1, class 2 Miller, again, proof of principle that we used at the early stage. Same technique, same relaxation. As you can see, apical matches suture. And in this particular case, we're so comfortable and confident that we did not do those interproximal sutures because we thought that the tissue, the epithelium, would just grow in and we would have a coverage of this tissue like we would have with the traditional connective tissue graft. And again, this was part of the growing maturation that we had in this technique and the failures that we had. And you can see here that a few months later, it failed. We did not get the amount of root coverage that we expected. But then the patient was not ready to move on to a touch-up surgery. So the patient moved out and said, no, give me a few months and I will come back to you. And 3 months later, look, we got crippling attachment. So the tissue healed and covered the site itself without us intervening again. And crippling attachment, as you know, belongs to live tissues. Crippling attachment doesn't belong to dermal product. Crippling attachment doesn't belong to any type of substitutes or membranes that are placed under tissue that are basically scarring or creating a scaffold. Crippling attachment belongs to live tissue. So a lot of the questions that I get from my referrals and from my patients that, well, I don't have pain. Why do I need to do root coverage? What is the benefit of me doing this root coverage? Why do I have to go to that? As we know, keratinized tissue and the amount of tissue is genetic, meaning that the endowment of tissue that you're born with belongs to you. But a recession is a pathology. You're not supposed to have recession. So patients tell you, oh, well, my mom had it, I have it, I have it. No, this is not the way it works. Recession is a disease and it has to be corrected, because if you don't correct it, the recession will progress. And this has been shown by Guido with his 35 years longitudinal study that shows that once a recession has started, it will keep going and keep progressing, and the attachment around the tooth will be compromised in the long term. But what is more important to understand, and this is for our colleagues dentists that do restorations, is that by losing attachment around the teeth and exposing the roots, we're actually compromising the long-term integrity of the tooth. So this is not only about periodontology, this is about saving the patient's teeth. By doing the root coverage, you're going to avoid root caries. You're going to avoid restorations on those roots. You're going to avoid sensitivity and the excessive needs of bondings and root canals on those teeth, and therefore improving the dental lifespan of your patient's teeth. And therefore, there is a restorative benefit associated with this technique here. Again, I'm just going to be brief again on this last part to show you that, again, this concept of promotion needs for you to have keratinized tissue. If you do not have keratinized tissue, you will fail. So do not attempt this tissue if you have only mucosa, but you need some keratinized tissue. We still don't have that number, and empirically, we think that 1 or 2 millimeters would be enough. As you can see here, this is a posterior mandible, very challenging case, and we're able to develop keratinized tissue and attachment on that tooth by having some keratinized tissue. If you do not have it, add your subepithelial connective tissue graft to it. There is nothing wrong to mix and match those techniques. Things actually do work better. This is, again, a very challenging case here. You can see where we were able to rebuild this attachment using the same technique, again, fulfilling the concept of bite integrity, volume, and modifying the surgical techniques. Again, you see these procedures are more challenging than a mandible, where you have to deal with the mentalis muscle and the surgical access, and you see we are able to develop some sort of keratinization and some sort of attachment around those roots here belonging to the patients without the use of any tissue harvested in the palate or in the tuberosity. This is, again, an extreme case here to show you, again, this is something that is not so common to obtain, but the power of this technique when used properly. We did a double papilla technique, coronary advancement flap, and PRF membranes, and look at the amount of root coverage we're able to obtain with this patient into a predictable way, and the thickness of this body type related to the new tissue formation. So, of course, all this information is anecdotal. These are cases. We have 100 cases to show you, but what is the data? What is the information now? Because, again, you're all scientists, you're all doctors, and you need to have information, data. This is, again, a publication that we just submitted. This is a 3-year retrospective analysis that we did on a 2D analysis. This is, again, cases done at USC with our students, residents that we use for the master thesis. This is, again, a patient study pool that had 12 patients, full arch restorations, meaning this is not, again, a 1 or 2 teeth type of restorations that we're doing, but these are full arch at the time, class 2 millers, and the patient had to have the prerequisite to have at least 1 millimeters of keratinized tissue, knowing, again, that this technique will not be suitable. It would be a big contraindication otherwise. And we have 3 years follow-up of this patient. So what we did here is that we took pictures of this patient, important in Photoshop, and we measured the vertical amount of recession that this patient had at the beginning. We measured at 3-year post-op the amount of recession, and then we superimposed by a calibration done by the software those 2 pictures, and we're able to quantify the amount of vertical gain. And at 3 years, we're able to maintain 82% of the vertical coverages that we obtain. So, which is wonderful. That shows that there is a certain stability of this gain in time, again, coming from the fact that we're using autogenous tissues through, hopefully, form of attachment that we have for this patient. Recently, we just finished now a 3D analysis on a different batch of patients. Okay, so this is not the same patient. It's important to understand that we have, this is, again, a 3D analysis. This technology didn't exist when we did the first study. So we basically scan our patients, transfer this into STL files. Now we have 25 patients, 25 arches. We're able now to superimpose by the technology that we have the volume gain that we have from the beginning and the after. And you can see in blue here, this is the before, and in red that you have the after, and this is the cross-section of the volume changes. And we see that in every single case, we did have a volumetric changes, improvement of the clinical outcome. And not surprisingly, the areas where we had most of the keratinized tissue, which is the canine and maxillary incisors, we had most of the volume changes, and the least amount was on the mandibular incisor, which is associated with the least amount of keratinized tissue. Used again to verify and the limitations of this technique. Okay, so as a conclusion, again, this technique works very well in class 1, class 2 millers if you have keratinized tissue. So it's a wonderful substitute. If you don't have keratinized tissue, please do yourself a favor. Do not use this technique by itself. Use keratinized tissue coming from the palate, from the tuberosity, and maybe merge those two techniques together, and you will see a jumbo clinical outcome with this technique. So I think this is my conclusion. So respect the body and its limitation, understand how the body functions, understand biology, and then try to merge these concepts that we have, that we understood, with proper sound surgical techniques, and then you'll be successful with your care. Thank you. So this is the conclusion of my presentation, Omid.
Thank you so much, my friend. What a presentation, what a clinical cases. As I said at the beginning of the presentation, I was pretty sure that I would be very impressed by this presentation, because I am a kind of soft tissue guy, and these kind of treatments really excite me, and I'm pretty sure most of the audience that are interested in soft tissue have been very touched by this presentation and this kind of approaches. So again, thank you so much. And I have some questions and some just want to share with you, because we're very expert in this field. So one of the things that you mentioned that I think is very critical and is the key is the presence of the keratinized tissue as a prerequisite for this type of treatment. So I just want to make it clear that keratinized tissue is necessary or attached gingiva is necessary. So if I have only 1 millimeter keratinized tissue. So if
keratinized tissue, you want to have keratinization.
Yeah. So the first video actually that you presented doing this technique in the canine area, and I noticed the left canine of the patient, there was almost no keratinized tissue, almost nothing. But can we say that because it's a multiple recessions, the neighbor teeth and neighbor keratinized tissue can help that one in the middle?
You know what? That's a very good point. It could be. You know, this observation actually it's the first time that somebody is bringing that up to me, and thank you for that. It's a very solid observation that you made, because we know that the secondary fibers and the tissue fibers communicate with each other. This is a mesh. This is a network of fibers that communicate from the tooth to the tissue and the tissue within itself. So it could be a remote positive impact of this upregulation from the neighboring site to the surgical site. It's definitely possible. Yes. Amazing observation. This is very good point. And thank you for bringing that up to me, because I never thought about it this way, but yes, it could be.
And one more thing that you mentioned, to pack as much as possible the fiber membranes. And
yes.
I wanted to write down the question, and immediately you mentioned that you have 3 devices in your office. So my question is,
yes,
most of the practitioners have one of the PRF machines. Most of them, I mean, because
yes,
they are not focused only on this type of techniques. So in that scenario, can they use these techniques or in these approaches in treatment recessions, or it's a limitation for them?
No, so basically there is different variations of this harvesting technique that you can have. If you're using just so we provide our patients with a sedation. We basically sedate all our patients in the office. So we are basically, with my wife, both of us providers of sedation. So all our patients are sedated. So we do have a port, basically a catheter that is basically inserted in the patient's vein during the entire time of the surgery. So if we need more blood, then we can go ahead and harvest more blood from the same catheter, exactly. Especially once now we need to use the IPRF at the end of the surgery, there has to be a second venipuncture, okay? So if you're doing IV sedation yourself, or if you have an anesthesiologist, then this is easy. This is no-brainer. If you are not providing IV sedation yourself or have access to an anesthesiologist, I know if you go on the website of Joseph Shukroun, I think process.prf, he has a technique where he shows you how you can leave the catheter inside the vein and attach some saline solution and flush the vein once in a while, so to avoid the coagulation, and leave the catheter on side. So that will allow you multiple harvesting if you have only one machine. So you have to be creative on that and just be able to plan it. Exactly. Yeah. So there are options. Yes.
And in also one of the cases that you showed that it happened to have a creeping attachment in the future. So at the, for example, in 2-3 weeks or 1 month, you faced incomplete coverage in like canines mostly.
Yes.
But in another period of time, you faced a creeping attachment. So one of the things that usually I think about soft tissue grafting is that it's very important for us to close everything and make the graft completely contained, whether it's connective tissue or PRF membrane, etc. So in that case, also you mentioned that we only had the apical mattress sutures and you didn't go with the sling sutures around the contacts. And that was why actually I saw the PRF was exposed around the margin. So can we say that the exposure made it more prone to incomplete coverage firsthand? And was it possible? Yeah. So you recommend complete suturing now, right? Because we cannot count on everything all the time.
There is no, this doesn't work. This was again part of the first cases. The cases I showed you are the cases that we did originally to show you the growth that we made from the surgical standpoint. And we try to see if you would get any epithelial creeping on the PRF membrane, and it fails. Okay, you're not supposed to leave PRF exposed. If you leave PRF exposed, it will resorb by the aggression of the tongue, the food, the saliva, the coffee, and the smoke, and everything. It has no chance to survive. So you want to cover your PRF membranes 100%. Any PRF membranes that is exposed, in my experience, has no chance to survive.
Yeah. And one of the other things that I noticed was the sling sutures around the contacts by Herzeler. It was interesting for me because in the original technique, they go two-sided. So once they enter from the buccal, they go around the contact, and again going from the palate again around the contact. I noticed that in the video, it was only from the buccal around the contact and then tied the nuts. So will it make any difference, or it's just for making the flap stable in a coronary position there? Yeah.
Yes. So that's a very good point that you're bringing up, because so the decision to make to see if we do a loop or no loop basically is the adaptation of the flap interproximally. Some teeth are buccally versed, some teeth are straight. So if the teeth are straight, just a single loop will be enough to get that coronary advancement. If the teeth sometimes, like maxillary anterior teeth, are versed buccally, the single loop will not be enough because you'll have a dead space. So creating the back and forth will squeeze the tissue more towards the bone and lift it up. So what we do, if we have a doubt, we try it and see which one will give you the best adaptation of the papilla on the surgical side. If the one loop is give you the same adaptation, then it's much easier. Obviously, it's, it's much simpler and much quicker. But if you see that when you do your loop, you still have a gap that is created on the papilla, and the papilla is folding, it's not really squeezed into the area, then you want to do the Hertzler, which is the going back and forth.
Yeah, I agree, because I think that's a good point from the clinical standpoint. And
yes,
I truly enjoyed this presentation. So I think we can talk like 24 hours about it. But my final question regarding the type of PRF, because you beautifully demonstrated that. We had a talk with Rick Myron like a week ago, and he also described the different type of PRF, the changes in the technology. He talked about comparing the fixed angle with the horizontal angle and quality of the PRF that we're going to gain. As you mentioned, APRF showed better results comparing to other types. So now my question is this: in specific type of treatment of recessions, can we say that the results going to be significantly different from the clinical point of view, not from the statistical point of view, with different type of PRF? So for instance, if I have an LPRF or APRF or CPRF, can I say that using different type of PRFs can have an effect on the type of outcome that I'm going to gain?
So to be quite honest with you, I don't have that experience because I started my PRF journey with APRF. Mm-hmm. So I started the utilization of PRF with APRF. So I have very little experience with the LPRF. You understand? So now, to be quite honest with you, we are not even using A or L, or using the low LLCC technique now. Mm-hmm. So basically, if you look at the paper published by Kobayashi and Sharam Ganati, this is actually the protocol that we're following right now. So the spinning protocols have changed right now, and this is the technique that we're using. So we're trying to drift away from A or L or I, but basically using solid PRF and liquid PRF into the treatment, understanding that the spins that we have for the LSCC technique will give you the best of both worlds. So it's mainly a streamlining that is happening in the community to try to avoid the commercial aspect, because that's the reality. There is a commercial aspect with these namings that we're trying to eliminate and just grant the biology, the title to the biology rather to the marketing naming. So we're trying to stay away from that today. So we're trying to stay from A, I, or L, but we're using the LLC concept, which is, I think, the most noble, the more scientific way of doing that. So hopefully that will answer your question. We're trying to eliminate that.
Yeah, exactly. Yes. I mean, I really enjoyed the presentation, and really thanks for your time, for all the effort, and all the beautiful cases, going in depth of the literature, and then step by step presenting the procedure, which I'm pretty sure is most of interest in all the dentists and all those people interested in soft tissue. And really truly appreciate your time, and again for accepting my invitation, and really looking forward to see you very soon, and also very soon in Iran.
Thank you so much. My true pleasure. Thank you so much for the opportunity.
Thank you, my friend.
Thank you.
It was nice talking to you.
Thank you, everybody.